A couple of other drugs. These drugs are not listed in the JNC7 report, but they are important drugs, and you'll have to see them prescribed for hypertension, so that's the reason I sort of have a separate slide on these. With our alpha blockers, maybe more familiar with Cardura or Hytrin as well. And they block the alpha receptors. Oftentimes you'll see this used for blood pressure control and also enlarged prostate. Prostate is full of alpha receptors. Some of the side effects is dizziness, fatigue, and orthostatic hypotension. And what orthostatic hypotension is the patient is sitting down or laying down and they stand up too quickly and they sort of get dizzy, lightheaded. That's orthostatic hypotension. Let me demonstrate how alpha blockers work. So let me take this up very quickly. So we have a blood vessel. I don't know if you can see it very well on the video now, but we have a blood vessel, and around the blood vessel we have alpha receptors. So we have the alpha symbol around the blood vessels, and when I refer to this as a fish or a fishy constricts, then we have high blood pressure. So if we take an alpha blocker, it blocks the alpha receptor from constricting, so we prevent hypertension. So this is how alpha blockers work. Next, we have alpha-2 agonists. An example is going to be clonidine. And oftentimes you'll see this used for hypertension. Also, you can see this used for other things as well, simply because of some of the side effects associated with this. So we may actually end up taking clonidine due to the side effects of the medication. And some of the side effects, fatigue, sedation, bradycardia, and perhaps even rebound hypertension is associated with clonidine. So this is a slide from the JNC7 report. So if the patient comes in with hypertension, we do lifestyle modifications always first. And then if we're still not at blood pressure goal, if it is stage 1, lifestyle modifications plus 1 drug. And the drug that the JNC7 report recommends to put the patient on as being that first drug is a thiazide diuretic. If stage 2, lifestyle modifications plus 2 drugs, one of which preferably is a thiazide diuretic according to the JNC7 report. And then you basically just mix and match. If one drug doesn't work, then you try another drug. If the side effects, patient cannot tolerate the side effects, then you try another drug or another drug within that class. We have many classes of drugs, so we can mix and match hopefully until we find the right combination. Now if a patient comes in and they have some type of problem, let's say the patient is a diabetic, then we may want to stay away from beta blockers because they can mask hypoglycemia. If a patient comes in and they're an asthmatic, then we may want to stay away from beta blockers as well. If there is some other condition going on, then we may have to give the patient a different type of medication. If they have congestive heart failure or if there's some type of kidney failure, then we may have to consider that when given the medication. And that'll be in another PowerPoint. So you keep mixing and matching these drugs until hopefully you get the patient at the appropriate temperature, the appropriate blood pressure. If not, then you'll send the patient to a hypertension specialist at that point in time. Couple last notes on hypertension. You want to treat aggressively. Watch for secondary hypertension because you may initially diagnose the patient with primary hypertension, and then 3 months, 6 months down the road, when the patient comes in for a checkup, you're able to diagnose why that patient has hypertension. Maybe they're taking some other medication, maybe they have some form of renal failure, and you can at that point in time, determine what is causing their hypertension and treat that. The use of a 24-hour ambulatory monitor, so the patient wears a monitor for 24 hours. And this is hopefully to prevent white coat hypertension, which is simply when patients get nervous around doctors, hospitals, nurses, etc. So the patient is outside of healthcare, they're fine, their blood pressure is normal, but when they come to the doctor's office, their blood pressure shoots up. So hopefully, the 24-hour ambulatory monitor is the best way to check for the white coat hypertension. Also, the JNC7 report recommends at least 2 readings after the initial screening to determine if the patient has high blood pressure or not. Case discussion, we have a 50-year-old female patient comes in the office for a checkup. Medical history is unremarkable. Blood pressure has been 155/90 on 2 prior visits. Physical exam is unremarkable. Patient is currently not taking any medications. What would you do? First of all, lifestyle modifications. Second of all, put the patient on a medication. And the JNC7 report recommends that medication be a thiazide diuretic, but that does not mean we always have to put a patient on a thiazide diuretic. Next patient we have is Mr. Smith. He's a 38-year-old male. He is coming in for an STD checkup. Patient is nervous about recent sexual contact. Medical history is unremarkable, and his blood pressure is 158/98. STD labs are drawn. Patient will be back in 1 week for results. What do you do? Well, this simply could be a case of white coat hypertension. He could be nervous, so he'll be back in a week for the results, and just recheck his blood pressure then. If it's still high, at that point in time, I would either recommend sending him to his primary care physician to be evaluated for hypertension, or if we are his primary care physician, for him to come in for a blood pressure screening minus this STD checkup that he'll be coming back for. In conclusion, treat aggressively. It is the silent killer. Contributes to cardiovascular disease. You want to watch for secondary hypertension, and you want to use the JNC7 protocols, and the JNC8 report should be coming out very soon. So keep your eyes out for the JNC8 report. That is all. Thank you very much.